Hi, everyone, and welcome. My name is Jen Elder. I'm the director of SAMHSA's Homeless and Housing Resource Center, and we are so excited to welcome you today to a fantastic webinar on Introduction to Psychotic Disorders. I have just a few housekeeping slides to begin before we kick off the presentation. So next slide. I'll start with a quick disclaimer. We are funded by the Substance Abuse and Mental Health Services Administration, but the views and opinions expressed today don't necessarily represent those of SAMHSA or the Department of Health and Human Services. Next slide. Right. As with all of our HHRC events, we are joined by American Sign Language interpreters and a live captioner. So we really appreciate them joining us today. For those who are looking for the captioning and the interpretation, if you have any technical difficulties, please reach out, let us know. We'll try to troubleshoot. You should be able to change the view on your screen and set that up on your end to have the view that fits with your preference. Next slide. A few instructions. So all participant lines are muted today. We also have disabled the chat feature. We are going to be joined by a large group of attendees. So we won't have the chat, but we do want to hear from you. So we are really grateful for all those who submitted questions during the registration process. I think we received 1,000 questions in advance of the webinar, and our great group of panelists went through them and started preparing some answers during the panel discussion. So we are going to hit on those hot topics. But as you have questions today, please use the Q&A feature to reach out. Even if you just have a comment that's not a question or something that you're really reacting to, reach out. Let the panelists know, things that you appreciate about their presentation. The slides are available now for those who want to download them and follow along. They're under the events and webinars section of our website. We'll also get the link into the chat for everybody. Perfect, thank you. A recording will be available very soon. We usually have that up in actually about 2 days. So that'll also be on this same page where the slides are. At the end of the webinar, we'll have a link to a brief evaluation. If you're looking for a certificate of participation, you'll be redirected there upon completion of that evaluation. If anything happens and you miss that link, again, go to the event page and we'll have that for you. We'll make sure that you get your certificate because we really appreciate you joining us here today. Right, next slide. So with that, that is all my housekeeping. We have a wonderful panel. They're going to introduce themselves a bit later, but for now, I'm going to turn it over to Aaliyah Warner, who's going to get us started today. Thanks, Aaliyah.
Thank you, Jen. Okay, I'm Aaliyah Warner. I'm a licensed psychologist at UT Health at the Harris County Psychiatric Center. I direct a program for schizophrenia. So a lot of what I'm going to be talking about is based on some experience and of course the literature. Okay, so what am I going to talk about today? So I'll give an overview of what psychosis is, how it occurs, some of the statistics associated. I'll also talk about stigma and some of the misconceptions of violent behavior among this population. We'll talk a lot about support strategies, and we'll talk quite a bit about de-escalation strategies, and then also some best practices or some practical skills that you can use with this population based on best practices and evidence-based treatments. Okay, so starting with some essential background information. So what is psychosis? Psychosis is a broad term that captures some symptoms like hallucinations and delusions, but it is not a specific mental illness. It's just a symptom. So we consider psychotic symptoms on a continuum, a large spectrum. At one end, we have people that experience severe and debilitating symptoms, and usually that's part of a diagnosable mental illness. On the other end, we have people that occasionally experience mild illusions, hallucinations, some delusional thoughts, right? And the main idea here is that the continuum indicates that there is a lot of normality on this continuum. under certain circumstances, anybody can experience psychotic symptoms. So schizophrenia and other psychotic disorders is the main group of disorders that we consider to be most commonly associated with psychosis. And schizophrenia spectrum disorders is just a group of different mental illnesses that are similar to schizophrenia. So schizophrenia alone is pretty rare. It affects about 1% of the population. But a little bit more commonly, about 3.5% of individuals will experience psychosis within their lifetime as associated with either schizophrenia or a mood disorder with psychosis. So when people have pretty severe bipolar disorder or major depression, we oftentimes see people experience psychotic symptoms associated with their mood episodes. So even more commonly, about 5 to 17% of individuals that do not have a mental illness will experience hallucinations or delusions at some point. And I've seen a lot of estimates that are actually way more. And they also kind of vary based on different culture and location. So just a note, I'm probably going to be using the words schizophrenia, schizophrenia spectrum disorder, and psychosis synonymously. But if I mean one in particular, because I'm talking about research, for example, I'll tell you. Okay. So as we said, psychosis can be a product of a schizophrenia spectrum disorder or a mood disorder. There are many other reasons why people could experience psychosis. Some substances can induce psychotic symptoms in individuals, and sometimes people will experience substance-induced psychosis for a little while after the substance clears the body. People can also experience psychosis as a form of withdrawal from substances, just based on what the substance is. Typically, though, the psychosis will resolve once the substance has cleared the body, but at the same time, when people continue to use substances and experience psychosis as a part of the substance experience, sometimes people now develop a new psychotic disorder that is a little bit more chronic, and they experience it with or without substances. Another main reason that people experience psychosis is because of delirium or other medical illnesses. There are a lot of different medical illnesses that can create symptoms that look a lot like psychosis. And delirium is pretty similar, right? Often people will experience psychotic symptoms when they're delirious. With these, though, once the primary illness is treated, or the medical illness, the psychosis tends to reside, unless we're looking at, a later stage dementia. Okay, why does psychosis occur? Really great question. We don't really know, but we have a lot of really solid hypotheses. So the main hypothesis that we use now is the stress vulnerability model. So the stress vulnerability model is basically just meaning that a combination of risk factors, like biological risk factors, like family history of psychosis, for example, or early substance use, paired with too much stress that it's unreasonable or difficult to cope with. When they come together, they kind of catalyze the onset of a mental illness. And so trauma tends to be a really common occurrence that kind of initiates this onset of psychosis or a mental illness in general. Not only are psychotic symptoms very distressing to a lot of people, but not always, it has a pretty widespread impact on individuals' lives. It can impact social relationships or even ability to trust others and engage. The majority of people with schizophrenia spectrum disorders have comorbid either medical illness or other psychiatric illness. Very early mortality, about 15 to 20 years earlier than our typical lifespan, which is really sad. And also people have difficulty attaining educational, vocational goals. And it's a little bit more difficult to maintain independence, depending. Not everybody is impacted in all these areas, but these are some of the common areas. Okay, so what are the symptoms? So probably the most commonly known one, right, is hallucinations. So hallucinations are considered experiences in any sensory modality. without an obvious external stimulus. So for example, hearing, seeing, smelling, tasting, or feeling something that isn't present can all be hallucinations. Delusions are basically strongly held beliefs. They usually don't line up with evidence, and they often tend to preoccupy people's attention. So there's a lot of different types of delusions that people experience. So some examples, people often have thoughts that others are attempting to harm them or manipulate them or their loved ones, believing that there's messages specifically for them in things that are meant for everybody, right? Like songs, billboards, commercials, things like that. Believing that they have special abilities or sometimes are a prominent person or a deity. Or sometimes people believe that other people have been taken over by imposters. Right? Keep in mind though, delusions are only considered delusions when they are abnormal given the person's cultural and subcultural context. So this can make it a little difficult sometimes assessing for delusions. So we really want to make sure that we are sensitive to and ask about their cultural norms and if other people believe some of the same things that they do, because we're often surprised. Disorganization. So this can be in two different ways. So disorganized thought process is when people are having a really hard time putting their thoughts together and communicating in a way that others can clearly understand. So also can be disorganized behavior, meaning someone is doing something that really doesn't make sense or isn't goal directed, but often it seems to make a lot of sense to the person at that time. So when we're talking about psychosis, we're typically talking about hallucinations, delusions, and sometimes disorganization. There are other symptoms, though, associated with schizophrenia and some other psychotic symptoms, so I think it's really worth noting. So negative symptoms. Negative symptoms are a collection of multiple types of symptoms that appear as if someone's previous abilities or experiences or capabilities have been taken away. So it's almost as if someone has taken your batteries out of your body. And that's kind of what it looks like as well, right? So this can look like people being a little bit more slow in their movements, maybe talking a little more slowly, maybe not coming up with a lot of spontaneous things to say, right? Not expressing a lot of emotion on the face, just disengagement or withdrawal generally, and limited interest or motivation. So these can sometimes look like depressive symptoms, but they are a little different and we can kind of parse them apart. Okay, there are effective treatments for psychosis and schizophrenia, very effective treatments. Of course, one of the main gold standard intervention is medication. And we're getting better and better at identifying new combinations of antipsychotics and mood stabilizers that work for individuals that have fewer and fewer side effects. Even though people may be adherent to the medication, though, the majority of people still experience residual symptoms or sometimes some skill deficits. So there's a variety of psychosocial interventions that we use that are evidence-based. So very frequently, CBT is one of the top recommendations, right? So CBT-based therapy, so we have something called CBT for psychosis, and there's a lot of different variants of this. Right. Family services. So this means providing education or teaching coping skills or providing support for the individual's families. Oftentimes, our service users live with their family or receive a lot of support from them. So this is a pretty important intervention. Also skills training based on whatever it is that they need. Oftentimes we're doing social skills training or daily living skills or whatever it is that they really need. Also, very, very important, supported employment, supported education and housing. And supported employment and education are usually done with someone who specializes in that area and helps them get competitive employment or helps them get back into school and help them move more towards their goals and values. Okay. I think a lot of people still hold this belief that people with schizophrenia don't recover and continue to get worse and worse and worse. But I think that's really important to highlight how common recovery can be, particularly when individuals are in treatment. So this slide specifically pertains to research on people with schizophrenia. This is a 10-year follow-up, meaning they were diagnosed with schizophrenia, and then 10 years later, they're doing more research, following up with them and seeing how they're doing. So it's important to note too, because people with schizophrenia, as opposed to people with mood disorders with psychosis, tend to have lower recovery rates. But despite that, as you see here, they're still very high recovery rates, right? So various studies have found that around 15% of patients totally recover at 10 or more years follow-up, and 35% have a total recovery at some point, meaning a year or more of symptom remission, no hospitalization, and engagement in work or school and within the community. An additional 35% experience recovery but are not working at that time. And then up to 64% experience sustained remission of all psychotic symptoms, meaning no to mild symptoms, depending on the study. Also, people don't really tend to get worse and worse. As people age, they actually tend to have fewer relapses as they progress. But there are some things that can impact outcomes, like continued substance use or other health behaviors. So rates of recovery vary quite a bit, and some of the factors that influence higher recovery rates are getting people into treatment as quickly as possible as soon as they experience psychotic symptoms. A lot of the research and clinical work right now is focused on identifying people before they become psychotic and giving them interventions to reduce the likelihood that they'll develop a schizophrenia spectrum disorder. So there are some things that we can look out for. That's kind of beyond the scope of this. Also, within the first 3 years of psychosis, if people are employed, they tend to have better outcomes. And also the utilization of recovery-oriented services overall. Okay. Another very common misconception is that people with psychosis are much more violent than others, which is often pushed by the media's selective coverage, which we see all the time, right? So, and also just society tends to have a pretty drastic lack of understanding of folks with psychosis. So while individuals with schizophrenia can be violent, just like anybody else, substance abuse is one of the largest contributors to violence among those with schizophrenia or psychosis. In fact, people with substance use disorders without schizophrenia and people with certain personality disorders are actually more frequently violent than those with schizophrenia. These exaggerated beliefs about violence among this population also adds to more societal stigma and self-stigma, which is internalized stigma. And these significantly impact outcomes. For example, stigma and self-stigma decrease treatment engagement and increase risk for suicide, which is already very high for this population. Another example, societal stigma plays out in the legal system. There have been some studies that compare individuals with and without psychosis that committed the same exact crime, but those with psychosis were 50% more likely to be incarcerated for a misdemeanor than those that didn't obviously have psychotic symptoms when they were arrested. So maybe a more appropriate focus for this population is the fact that people with psychosis are traumatized and victimized much more than the general population, meaning they're more vulnerable than violent. The risk of victimization among those with schizophrenia is 4 to 6 times higher than the general population, particularly if they're unhoused, if they're unemployed, or if they have a history of abuse. Research estimates indicate about 90% or more of people with schizophrenia have experienced traumatic events throughout their lifetime. And this tends to kind of fuel a cycle, as trauma is a primary risk factor for the development of psychosis and is also a risk factor for re-victimization. And so unsurprisingly, people with schizophrenia spectrum disorders have higher rates of PTSD than the general population. People with psychosis also experience trauma or re-traumatization in facilities or healthcare systems. So it's really important that we're aware and sensitive to misconceptions and the likely trauma histories of our service users. So it's important that we try to use trauma-informed care to assist with recovery and to prevent re-traumatization. Okay, so now we have the background information. So now what do we do? The most essential skill we can develop and utilize with all populations is empathy, right? The ability to put ourselves in someone else's shoes and have a sense of understanding of others' experiences and emotions. Sympathy, on the other hand, is feeling pity or sorrowful for others' misfortunes. This creates more emotional distance and lacks the spirit of hope, as we're kind of like looking down as opposed to experiencing with. So empathy is really what we're going for. Cultivating and using empathy is also the backbone for most all effective strategies for working with people with psychosis. However, some might find it difficult to empathize with these experiences because they're kind of difficult for us to imagine, right? So there are a few strategies we can use to cultivate empathy for others with psychosis. So one would be trying to put yourself in other people's shoes by imagining if a delusion was true for you, how would you feel? So you can take a moment to think about a service user you recently had an experience with that told you about a delusion. If you were to imagine that you believed that and that was true for you, how would it make you feel? So for example, one of the most common delusions I hear is so-and-so is surveilling me and wants to kill me and my family. If I were to imagine what this was like, I would feel terrified. And perhaps I might start thinking, what did I do to make someone else so upset with me that they would want to take my life and my family's lives? I might assume I must have done something terrible, right? Maybe I don't know what it is though, so maybe I'm just really a bad person. I'd also feel really unsafe, unable to form relationships, unable to go to work. I would probably really just be focused on the fact that I'm going to die, right? So this can kind of give us a little glimpse into what it might be like for someone who's experiencing these types of delusions, because remember, for them, this delusion is their reality. Other ways to foster empathy include imagining what it would be like to have little social support, feeling stigmatized by society, or feeling crazy or broken or rejected. Voices are very common, and there are some simulations on the internet you can use if you're interested to see what it's like to hear voices and try to concentrate on even some simple conversations. It's very difficult, and I use this exercise with some of our interns and resident trainees, and every single person has difficulty focusing on the simple task that we give them. Okay. Oftentimes, we assume that people are acting or experiencing things because of who they are and what they did. This is what we call the fundamental attribution error, and it's a mistaken thinking. So instead of assuming that people are acting in ways because they want to, or because they're bad or malicious or unmotivated, we can instead consider what happened to them that made them this way right now, right? Often, people are doing the best that they can with what they have and what they've learned. Keep in mind that many times people never learned healthy coping skills or interpersonal skills or problem-solving skills, right? So we can use this as an opportunity to teach and model effective ways of coping or handling situations. Okay, so now we have the empathy. What do we do with it? There's a lot of ways to express empathy. So actively listen, really listen, and try to understand. To understand more fully, we ask questions, right? So we ask questions to more fully appreciate the situation. We want to ask what they know, what they believe, what they want, what they think, what they feel. And the more information you have, the more able you are to empathize and act effectively. And the more others can tell that you're empathic or striving to be empathic. Will feel heard, which communicates empathy. Further, we can provide reassurance or guidance if that seems like what it is that they need. If we're not sure what they need, we can always ask, how can we help? And that leads us into behaving empathetically. Sometimes we can predict what someone would need or want by using empathy and behaving accordingly. This might look like making a small change in their environment to make them feel safer, or using reinforcement when they do something good, like a high five or verbal praise. We can also use reflections and validating statements, because these require empathy, and we'll get to those in a few slides. Okay, So I thank you all for all of your questions before this workshop occurred. And a lot of questions around how do I keep myself and other people safe psychologically and physically? And that is an excellent question. And so the next little while, we're going to be focusing on de-escalation strategies. We'll talk about prevention, warning signs to look out for, skills or strategies that are both nonverbal or verbal, and then specific clinical techniques we can use. Okay. Escalation is best prevented when possible. There are a few strategies that we can use to decrease the likelihood of escalation. So one is collaborative decision making. So when patients are included in treatment decisions, they're much less likely to see you as an adversary and less likely to become upset. And so this includes having service users be part of decisions such as which treatments they would prefer, which resources they're open to pursuing, and everyday choices like what they eat for lunch or for snacks, right? This also means being transparent when needing to use restrictions or other interventions that might be necessary but are undesired. We can also prevent escalation by managing the physical environment, keeping noise levels low, maybe not having SVU on the television, avoid blocking exits and people's ability to ambulate freely, and also respecting patient privacy while still ensuring safety, so that keeping doors unlocked if possible. We can also make sure to manage the social environment. We can keep consistent schedules, and if things are going to change, offer notice in advance so people have time to prepare or adjust what it was that they were expecting for the day. Creating an environment that consistently praises or recognizes good behavior is a good way to manage the social environment. Also, be sure to be aware if other service users are being bullied or if there are unwanted physical advances towards other users, because we want to be able to address those. And most of the time, our service users already feel unsafe, so we want to make sure that we're implementing changes or making people feel the most safe as we can. Also providing leisure pursuits or activities, like in a milieu, for example. It can also be helpful to ask patients about their triggers and coping strategies when they're calm or at the beginning of their service utilization, because this provides us then opportunity to identify their warning signs before agitation occurs and reminding them to use those coping strategies that they already know. So oftentimes when we're escalated, we forget all of the things that work. All of us do. Maintain awareness about warning signs. So, excuse me, it's important to be aware of any warning signs of potential agitation, like nonverbal signs like pacing or restlessness, verbal and behavioral signs associated with fighting, like clenching your jaw, increased breathing rate, staring, verbally louder speech, maybe profanity, or hostile comments, sometimes like muttering under the breath. Those are things to look out for. I forgot to mention, avoid arguing and ignoring. This is really important. Try to avoid arguing with patients. So this also means for psychosis, do not argue with service users about the accuracy of their psychotic symptoms, like delusions or voices. This almost never is productive unless it's within the context of a long-term therapeutic relationship, or if they're deliberating the validity of these experiences and are asking explicitly, is this real or not, right? And even in those contexts, though, it still isn't an argument. It's more of a collaborative exploration. Okay, so before we get more into what to say and not to say, it's important to acknowledge the power of nonverbal behavior. The outcome of our interactions is mostly a result of how we say something as opposed to what we say. This is particularly true for escalation, because the more amped up people get, the more quickly they're going to respond to your nonverbals and your behavior, and the less likely that they are to actually listen to the words that you're saying. So assume non-threatening behavior. You can see already probably that I use my hands a lot, but using excessive hand gestures in the milieu and when someone's escalated can trigger some like hypervigilance or maybe some previous traumatic experiences that make them feel a certain way, or could just be threatening in general. Respect their space, generally 2 to 3 arm lengths away if you can. This is for them to feel like they have a respected amount of space, but also so you don't get hit or harmed, right? Avoid touching the patient unless you know them really well and like under some very small circumstances or rare circumstances. Use effective self-talk if you can. If we're telling ourselves that we can't handle something, we're going to panic, right? But reassuring ourselves, I can handle this, I know what to do, can really boost how effective we are in de-escalation. Appear open and relaxed. This kind of goes with a non-threatening behavior, right? Look empathetic. Look like you're ready to listen. Don't like do anything that looks like you might be ready to fight with them, right? If they ask irrelevant questions or challenge you, try to ignore the challenge, not the person though, and just gently redirect them to what the issue is at hand. Okay, so regarding what we say, there are 3 main statements we want to avoid as they tend to invoke anger. Limit setting. This is telling a service user to stop doing something without adequate rationale. So for example, I'm sure many of us have been told, calm down, which is considered limit setting because you're being told to stop caring about something, which is an unreasonable ask, right? And being told to calm down tends to have the opposite effect, instead makes us more upset. So in addition, limit setting without like a rule or rationale can create a lot of inconsistency across providers, because you might tell them to stop doing something and another provider another time might allow it. And so we don't want to have like inconsistent responses or limit setting across providers, because it's going to create more of a hostile environment. Okay, activity demands. So telling someone to do something when they don't want to or don't necessarily need to, like telling them to sit down, lower their voice, etc., without providing any rationale or alternatives. Saying no when the requests are reasonable, like kind of reminds me of, when we were kids and our family said, no, you can't do that. And you ask why, and they're like, because I said so. So recommend against that. All of these 3 statements take away a sense of autonomy and a sense of choice, which are typically already limited for our service users. And oftentimes, people will show us that they have autonomy or the right to choose by showing us otherwise. So doing the opposite of what we tell them to do. So don't do those things. However, they are pretty natural, right? It's just part of what we do and how we interact sometimes. So if you do them, don't worry. There are alternatives, and it's a way to grow. So one alternative, grieving with the person. So if we want to do something for them, but we can't, we can tell them that I wish that I could help you and I can't, right? So it's still empathic and getting to the point that that's not something that you can help them with. We can also give them some choice, even if it's a small choice, so it still gives them a sense of autonomy. So for example, would you like to sit here or there while you wait? Would you like me to tell your doctor, or would you prefer to tell your doctor yourself? We can also use prompting, which means setting up if-thens, right? Meaning if they do something that you ask, then you can do something for them. Like if you lower your voice, then I can understand better how to help. Instead of just telling someone to quiet down, you're adding incentive. If you do this, then I can help you with this. Or if you practice breathing for a few minutes, then I can go check on whatever it is. Because this is also encouraging them to use coping skills and priming them that this is probably a good time to use them. We can also apologize if it seems appropriate. Everybody has a different comfort level with apologizing, so only use it if you feel comfortable doing it. Typically, we can apologize to show empathy. Like, if someone has some bad news, we tend to apologize, like, oh, I'm so sorry that happened, right? We can also apologize if we made a mistake. Service users tend to be less upset about mistakes if we apologize. And there's a lot of literature on this regarding like medical malpractice suits and things like that. It's pretty interesting, actually. And in general, apologizing tends to make people feel validated, feel more calm, and feel heard. Validation. Validation is a type of communication to a person that their responses make sense and are understandable within their context or situation. So validation requires a non-judgmental attitude and acceptance, and for you to identify what is valid or finding the nugget of gold in the sand, to find what specifically is valid within what may otherwise be a very dysfunctional response. So this can mean validating people's emotions, thoughts, or behavior based on whatever makes sense given their history and the current situation. While experiencing empathy does not always result in validating expression or behavior, validation does always require empathy. Why validate? There's no easier way to ease somebody else, right? It also facilitates both our service users' emotions and our own, because if we are validating someone, we are making sure that we experience empathy first, right? And we're also acknowledging whatever it is that contributed to their behavior or how they feel right now, by trying to find what's valid. How to validate and what do we validate? We validate the valid, meaning we find the kernel of truth of whatever is going on and indicate that. Excuse me. We don't provide validation for behaviors that are not understandable within their context, though, because we don't want to reinforce something that isn't helpful. So for example, if a service user is angry because the voices won't stop making derogatory statements toward her, so she's yelling and making rude comments to others, we can validate that it makes sense she would feel angry, but not reinforce her interpersonal behavior, right? Validation can be really reinforcing, which means it can increase the use of certain behaviors. We're all learning every day, and we use reinforcement and feedback to learn, even if we're not aware of it. So we want to make sure that we're setting up the best types of learning lessons for others. Okay, we can make validating statements, which are sometimes in the form of reflections, which we'll get to in the next slide. We can also act in validating ways, like providing an extra blanket when they know they're feeling cold, or providing a phone number to a place they're trying to contact. Using and, not but. So if we have two statements that we're saying together, it's preferable to say and. So like if we're grieving with them, I would love to help you and I can't. If we use but, which is kind of second nature because of how we write, it takes away from the first part of the sentence, like you would love to help them, but you can't. The first part is no longer a big focus. So maybe another example, if we say to ourselves, I want to see my children, but I'm in pain, you're probably not going to go see your children, right? But if you say, I want to see my children and I'm in pain, the outcome is less clear. Perhaps you will plan to see them despite being in pain because both are true in that moment. Perhaps even more powerful is switching the statements in order. I am in pain and I want to see my children. Now this is kind of like a motivating statement, right? The outcome is much clearer. If you'd like to learn more about that, I would recommend looking into motivational interviewing. It's a really helpful skill that everybody could use in almost every context. Okay, so what about psychosis? The same exact things apply, right? So when we're working with a delusion or an invalid experience or behavior, we can still usually validate the emotion, as it's usually valid that they would feel a certain way, given what they believe seems like it's based in reality to them. So it would, of course, make sense if they experience that emotion. Here is a pyramid of validation. It's not really important to know the different levels, but I'm just going to present it this way. So I'm going to start with the bottom, which is the most simple type of validation, and moving up. Okay. So, and different people require different levels of validation, but you can learn that as you go on. So the first one is nonverbal listening. So simply by paying attention, looking concerned, asking questions. This is validating. I'm validating that like you are a human with experiences right now. Reflect accurately. So restating back what someone tells you and seeing if you have it right, and also being open to if you misunderstood, like your reflection was incorrect, and then rephrasing or reconceptualizing what it is that you think they're experiencing. Read behavior, imagine emotion. If someone is like really restless and moving their legs up and down or pacing, we can imagine that they would be feeling pretty anxious, right? So an example might be, you seem pretty anxious right now. Is that what's going on? Given past events, of course. So here we're focusing on the fact that all behavior is caused by events occurring in time, and this behavior is understandable. So we don't need to agree with the behavior, but the underlying sense here is that we're saying it makes sense that this is what you're doing. So trauma response can come here quite a bit, like I can see why you stopped driving since you were in a terrible accident, or I can see why you don't like to go out at night, right? Or that you stay up at night. But we don't need to validate the behavior that's invalid, right? So if somebody is staying awake all night because they're paranoid, the behavior isn't really reasonable, but we understand why they would be experiencing and behaving that way based on the context. A way to respond to this is to say just that, and also to validate with action. So like if somebody needs something, providing, whatever it is that they need. Or if someone has a problem, help the person solve it, unless they just want to be heard. If they're hungry, give them food. The highest level of validation is being genuine and authentic. So this is treating individuals as equals and being well aware of their strengths, their capabilities, and the ability to grow. This is the opposite of being condescending or treating others as fragile. So when using this, we treat service users as if we would our own family or friends. Okay. Reflections are statements or rephrasing what someone told you and repeating it back to them. So this shows that we're on the same page, we understand, we're listening, we're right there with them. And reflections can be very validating. The most powerful reflections are the ones that hone in on the emotion, even if they don't tell you what it is. There's multiple types of reflections. The main two I'll just quickly focus on are simple reflections that are basically restating what they said without adding anything additional. And the second is taking what they said and imagining and the underlying greater meaning of it, or finding the underlying emotion and then stating that back. So you're adding something that you're assuming to the restatement. So for example, someone says, everything is wrong. You might say, nothing's going right for you. So that would be a rephrasing of what they said, right? But still validating. If you want to take it a step further, you're feeling overwhelmed and you don't know where to start. They didn't say that, but we can kind of assume that they are feeling that way, and this kind of catapults the conversation into like a deeper area for work. For voices, we can again reflect emotion, right? Especially if they look like they're not having a good time. Disorganized statements can sometimes be difficult, but usually they bring up some type of theme or something repetitively. And we can still reflect back by saying, whatever the theme is, seems really important right now, right? Or if they seem stressed, you seem pretty stressed right now. Let's try something like to distract or to calm them. How do we reflect delusional statements? So there is an acronym we can use that's STEP: summarize, test you're accurate, empathize, and proceed. So here's an example. So a service user says to you that Beatrice is using mind control to make her go crazy. We can be empathic and validating here by asking more questions to understand how she came to this conclusion. So we can summarize. So for example, after you talked to Beatrice, it seemed like she was calling you stupid when you walked away and you heard a voice telling you she was messing with you. This is just a longer reflection. Then we test if we're accurate. Is that about right? Do I have that right? And then we can empathize. First, by imagining, how you would feel in the situation if it happened to you and why. So we can empathize here by saying, that sounds upsetting, especially since you trust her. Here we're using a validating statement by saying, given the context, it makes sense you would feel this way. And then we can proceed. Can we try something to help you feel not as upset? So these can be very simple distracting techniques, doing something leisurely like a coloring, a relaxation technique. And when we're doing therapy, this can also be a really great lead-in to the rationale for focusing on some type of intervention. Okay. This is really important. So it can be really hard work focusing on helping others all day, and we often don't take care of ourselves. However, we really can't be effective if we don't take care of ourselves first, and we may be more likely to accidentally escalate others and have difficulty de-escalating if we're not well ourselves. ABC Please is an acronym taken from dialectical behavior therapy, and it's helpful for everybody. So A is accumulating positive emotions. Do something that you enjoy. Even if you don't have a lot of time or money, it can be something really simple, right? Like calling a loved one, going for a walk, cooking something that you like, or having a good meal. B is building mastery. We all need to experience a sense of effectiveness, productivity, or like being skillful. So try to do things that make you feel like you're accomplished, or doing something that you know that you're good at, like maybe a hobby or something, or just like get some things done. Crossing off things on a to-do list is incredibly rewarding. Hope ahead. If you know something is coming up that's going to be difficult, try to rehearse in advance and set up what types of coping skills you might use so that you can cope with it afterwards. These are the basic essentials for mental health, right? If we have physical illness, we need to make sure that it's being treated. We need to balance our eating. We know the things that we consume have a really big impact on us psychologically. Avoid mood-altering substances. Maintain good sleep. If you can't, try to seek out some services if you can, and get exercise. This doesn't need to be intensive, even just getting your body moving. Okay. Here are some additional strategies that we can use for most individuals, particularly those with psychosis. So, I mean, unless we have a lot of training or experience using therapy in the long term to assist with changing psychotic symptoms, the best thing we can do is help our service users cope effectively with the distress associated with the psychotic symptom, right? So relaxation techniques are incredibly helpful. We know that stress makes most psychotic symptoms worse. So if we can help them relax, this is going to have, a really positive impact on their experiences. So this can be anything. It can be, imagery, taking a mindful walk, practicing a breathing exercise, or any other skills that you may already have. This could also be engaging in any recreational activity. Distraction techniques can also be very helpful. So we can refocus someone on something else that's going on, or change the topic to something that they're interested in. We can ask them questions to facilitate positive memories, or you can use this as a coping skill in the future if you identify positive memories that they can think about on purpose when they need it. Some questions that might facilitate positive memories would be asking, like, what is your favorite holiday? What's your favorite holiday meal? Or did you play sports in high school, or what have you? Education and normalization. If you know enough about their condition, service users and their families highly benefit from learning about their mental illness and the treatment. We do need to make sure that we're using normalizing language, though, and frame psychotic symptoms using more non-pathological language. Otherwise, we can contribute to stigma more here. Socialization. You may have already noticed that folks with psychosis experience more severe symptoms if they're isolated and alone. So get service users out of their rooms, socialize with them, have socializing activities on the milieu, and praise good behavior. Overall, if we hone in on individuals' aspirations and strengths, our relationships are going to be better, others feel more hopeful and empowered, and they're more likely to make positive steps toward their recovery. And many people with psychosis are more successful than me and most of us, right? So there's really no need to limit their goals or aspirations based on what we think at that time. And remember, people need support and hope to grow. So these are two very simple techniques that I use often. And although they sound very simple, service users tend to love them. The first one is called look, point, name. So basically you just say, hey, you want to try a silly game with me? I'd like you to look around the room and just name every object that you see in the room and give them a while so that they go through as many as possible, and then have them go through the colors. And if they're engaged in it, we can do full grounding, which just means using every sense, right? So this is the visual part of grounding, everything you can see. Take a moment and listen and tell me everything you can hear. If you take a deep breath, what do you smell? Can you taste anything? Tell me anything that you can feel on your skin, right? This tends to get people out of their heads and back into the very moment. It can be pretty calming. See, my time is low. So these are some additional resources for folks in crisis. Hopefully y'all are aware of 988 for the suicide or crisis hotline. There's also other specific hotlines for specific populations. So for example, LGBTQ has their own hotline, which is here. Dr. Carnes is going to speak a little bit more about inpatient hospitalization as a resource for our providers that might need that. On the right here, we have some additional resources for more information. And also, if you're interested in more training on how to do some of the evidence-based treatments for serious mental illness, some of those are included here too, which I would highly recommend. These are our references. Okay. I think these are posted online, so I don't think I need to stay here. But someone correct me if I'm wrong. All right, so thank you all for listening. I will transition now to our panel discussion. Y'all had, like I said, you have really wonderful questions. So we hope that we can answer most of them today. So I'll let everybody introduce themselves. Dr. Carnes, do you want to start first?
Sure. Hi, my name is Dr. Brandy Carnes, and I'm an inpatient academic psychiatrist in Houston, Texas. And I'm really excited to be here to talk about psychosis. I think it's so important, and we're really looking forward to answering your questions.
Dr. Cuellar.
Hi, I'm Dr. Amy Cuellar. I'm a psychologist at the Michael E. DeBakey VA Medical Center in Houston, Texas, and I work in a psychiatric rehabilitation program called the Psychosocial Rehabilitation and Recovery Center.
Missy, do you want to introduce yourself?
Yes, hello everyone. My name is Missy Boyd. I'm a mental health peer specialist. I work with the first episode psychosis department at the Andrews Center here in East Texas, and I'm here to talk about my own lived experience with psychosis and recovery.
Excellent, thank you. So I'll start with some of the main questions that the audience had before, and while some of the panelists are discussing this, I'll take a look through the Q&As and see if there are some that maybe we could get to. I'd like to start by asking the panelists, what is the best advice that you have for people that are starting to work with individuals with psychosis?
I can go ahead and get started. And I think that first that my advice to people would be is to really try to understand that person's individual experiences and see them first as a human being. Sometimes we can look at somebody through the lens of only their diagnosis, but somebody is so much more than any sort of diagnostic label.
I agree. And to follow up on what Dr. Cuellar said and what Dr. Warner said earlier, like people experiencing psychosis are people. Even people with severe medical illnesses like diabetes, even if it's been so severe that they've required hospitalization in the past, you wouldn't spend most of your time talking to them about like how they manage their blood sugar or how their blood sugar readings have been. And so focusing on what makes that person them is really important. Like, what do they like? What are their goals? What do they see in their future? Can be really a very humanizing way to talk to people and not just prioritize their illness.
I agree. Also, when I work with a new client, the way I start, honestly, is just like Dr. Warner talked about many times, is to validate. Is to validate their thoughts and their feelings, and to validate what they want, what their goals are. I think that's a good foundation to start, and I think that puts the client in a good perspective to understand what their recovery path is going to be.
Wonderful. Thank you. There's so many really good questions in the Q&A box. Okay, so Missy, could you expand on, what do you wish people would have said or done when you started treatment?
In hindsight, which is 2020, as we all know, working in the department that I'm in now, it is what we call a collaborative or integrated department, where everybody talks with each other. We work with the doctors, the nurses, the therapists, the counselors, the case managers, and it's just such a fluid way of getting people through treatment and on a road to recovery. I really wish that was available to me when I started treatment. Not to knock the center that I went to, because they were fantastic, but it was incredibly stressful and hard to go back and forth between voicemails and text messages and appointments and receptionists and back and forth to different offices. It made it incredibly stressful, and it also was kind of degrading because, and from my experience, when I started treatment, I was in a very low place, and to climb myself up that ladder that hard, it wasn't a very productive use of my time. And so I wish I had that integrated care that I provide for my clients now.
Thanks, that's really thoughtful and helpful answer. Okay, we have a lot of questions about medication adherence and basically how do we get someone treated if they have lack of insight. Let's start with medication adherence. Anybody have any advice about, how to help people continue medication treatment, especially if they keep, not using or have any barriers or just don't want to use medication or don't think something's wrong? Dr. Carnes, you want to start?
Sure, I'd be happy to. I think there's so many different considerations when you think about why someone might not be fully adherent or might not be taking medications at all. If any of y'all have ever had to take a medication on a daily basis, you know how hard it is to be consistent. One of the things that I think about as like the prescriber of medications is things like timing and side effects are like the biggest things that I always want to consider if someone is wanting to take medication. Sometimes people will have medication regimens that are prescribed twice a day, and maybe they forget every morning. And so is there a way we can change the structure of their medication so they only take medications at night? If a medication they're taking during the day is making them tired and that's why they're not taking it, can we move that to nighttime? Can we find a way to simplify the regimen so that it works better for the person who has to take medications? Sometimes we can even use like long-acting formulas of medications that last for 1, 3, 6 months. And for some people, that's a really helpful strategy because they want to take medications. It's just really hard when life gets in the way. Like Missy said, you've got so many things going on. It's really easy to forget things like medications. And when it comes to things like side effects, I always talk with patients about how long might they expect these side effects for? Would they go away? Would they get worse over time? Should we switch to a medication that doesn't have that same risk? And really sort of collaboratively engage with this person about what would work best for them and how we can structure the medications so that it's functional.
Excellent. Something that I would add, when individuals are, I think this applies in both situations when individuals are using lots of substances and don't really see the need to change, or if, individuals think that, usually they believe that their experiences are based in reality. I think a couple workarounds is kind of similar to what Dr. Carnes was saying, is first getting their beliefs about medication. Oftentimes people have a lot of misconceptions about what medication is. Sometimes it's very frequent actually, people think medications are addictive. And so describing that difference, I think, can be really important. And any misconceptions, especially, family, cultural beliefs about why mental illness occurs is highly related to what type of treatment they think is needed, right? So really talking about beliefs and seeing if you can make any changes there. Also, people might not say, I'm hearing voices, or I'm delusional, right? But even when people are grandiose, there's usually a clear issue that something is getting in the way of people pursuing their values or what it is that they want in their life. Like oftentimes people want to work, right? And so what's getting in the way of work? And even if they can't say like, oh, it's my schizophrenia or something, which is not the language I would recommend either, we can connect, okay, well, there's something here. Is there something that maybe we could modify or do to see if it would work, right? So connecting treatment with whatever their goals and values are in the future. Then we have a little bit more flexibility.
Yeah, I think one of the things that you highlighted is really how important it is to identify like what are their goals and what are the barriers, and like how can you connect that medication or that treatment option to those goals. And one of the things that's also important to consider is like any social barriers. Like Missy was saying, sometimes it's really hard to get to all of these different appointments and all these different places and coordinate with these sites. Sometimes people have transportation difficulties or financial difficulties. And so how can you help with like community programs to deliver medications to patient? How can you use like telepsychiatry or like telehealth intervention so that they can see mental health practitioners or peer support specialists without having to travel? From a prescriber perspective, some of our medications can be very expensive. One of the medications that we use sometimes can cost up to like $1,000 a month, which is not something that most people can afford. And so really prioritizing how can we make this treatment plan work for this person is important.
Dr. Cuellar, do you have any ideas of like strategies that we can use to help people remember to take meds if they want to take them?
Yeah, sometimes people don't take medication, as I referred to before, because they just are having trouble remembering to take it. So there are some strategies that you can use. So for example, using, we'll call it can't miss reminders. So putting medication in a place what's going to be obvious next to, some place that they walk by every day, using pill organizers and talking about leaving the lid open when you have already taken your medication, so that just at a glance, whether you've taken the medication or not. Using alarms on your watch or your phone can be helpful. And then also, linking taking medication with something else the person does every day. If any of you have ever used a medication that needs to be taken 3 times a day, maybe you've used a strategy of linking that with breakfast, lunch, dinner. And so linking those behaviors can be helpful in remembering to take medication as well.
Definitely. Missy, anything else that you would add? Like what made it easier for you to engage in treatment or things that got in the way?
When it came to the medications, in all honesty, it was about education. It was not just Googling it, but talking to the doctors, the nurses, Friends of my families are EMTs. Got on support groups on social media and talked to different people about medications and side effects, and how long it takes to actually fully take effect and things like that. I think that really made the difference in because in the end it was kind of a mutual decision between me and my psychiatrist as to what medication regimen I was going to be on, which I have been for the last 3 years now. So I always push education when it comes to my clients when they ask about medications and things like that. I think that's the best way to approach it initially for me.
Excellent. Thank you. Yeah, and all this being said, not everybody has to take medication either. I mean, it's recommended for a lot of folks, but many people can manage it without it, or at least, want to try. So, it's also an option. Someone had a question, I think, about how do we help people stay adherent to medication without giving them maybe like the access to excessive medication to overdose. Dr. Carnes, I don't know if you covered this. If you did, I'm sorry, I was reading.
I didn't. It really depends on what sort of community resources you have and what sort of like support system you have. So for instance, ACT is a like national model. And one of the things that ACT does, assertive community treatment, they have a model where they dose people certain amounts of medications at a time. So there might be a period where you get like 2 pills and then 2 pills and then 3 pills, and you gradually work your way up to like 1 week at a time to 1 month at a time to filling the medications by yourself. And so it's a stepwise approach to like more independence and more self-control over that regimen. Sometimes if people are in more structured settings like group homes or nursing homes, they have the medications administered to them. But if families are ever really worried about the risk of overdose, sometimes you can make collaborative decisions with the individual about like, how can we mitigate these risks in the meantime, and how would we know when you're ready to be more autonomous or take on more of that responsibility yourself. It's really just an individualized decision based on what kind of resources you have.
Thank you. What about non-medical treatment? How do we get people into or interested into psychosocial interventions, particularly if they don't think that there's anything wrong? Any ideas on that?
You can always go over again, like the person's goals and values and how they believe that they're progressing towards their own goals. And you can use motivational interviewing techniques to highlight maybe the discrepancy between their behaviors and their goals. And I will say that all this we said in the context of it's difficult to access psychosocial services and psychotherapy. So, being aware of what resources are out there and realistic for a person to get is also important, because it can be hard to track down. So if there's any way that you have access to what's available in your community, in terms of maybe low cost options, places where people have some knowledge of how to work with people with psychotic spectrum disorders, that's always a good thing too, because it can be overwhelming to try to find treatment.
We had a lot of questions on, which makes sense, like within the homelessness context, how do people maintain access to medication? As Dr. Carnes, I'm sure you hear this all the time too, that they got discharged and then someone stole their medication. I don't have an answer for that.
It happens a lot. It's really stressful. And it goes back to community resources and what's available. If I ever have a patient who is really worried about maintaining an access to medication and knows that they can't have pills for some reason, maybe they have housing instability, they're worried that somebody might take them. A lot of times we talk about like long-acting formulations. because they are like injectable formulations. And so you take it and it's good for a month. Some of them are good for up to 6 months. And that can be a really easy way to make sure that people are staying on the treatment they want to be on without that risk. But it can be really hard if people don't like that option. Not everybody wants a long-acting injection, right? It's very dependent on the person. And it goes back to what community resources you have. Here in Houston, we have something called Healthcare for the Homeless. And so there are certain places that are specifically designed to provide mental health services for homeless people and give them medications there so they don't have to go to another pharmacy. It's more integrated, like Missy was talking about with her program. One of our big goals is if people want to be in more stable housing, helping them access more stable housing. Whenever you're not in stable housing, for a lot of people that can drive up your stress, and driving up stress is going to increase psychotic experiences. And so that can really defeat the purpose of treatment. But like I said, it all goes back to the individualized approach and what community resources you have available.
I see a couple questions about how do core beliefs and automatic thoughts relate to psychosis, and also how is it true that people can manage without medications? And so I want to speak to that just briefly. CBT for psychosis is an effective treatment for acute and subacute psychosis with or without medication. So, not for everybody it will work, to improve functioning to like where they want to be. But there are several strategies and therapy models that can really improve psychotic symptoms. And that kind of goes to the other question a little bit about core beliefs and automatic thoughts. So for those of you that are familiar with CBT, what's amazing about CBT for psychosis is delusions, interpretations of hallucinations, all of these things boil down to the same core beliefs that we're familiar with for those with depression, those with anxiety, things like that, right? Like if we are experiencing ideas of persecution, we think someone's going to harm us. Well, what does that say about us as a person? Well, it might mean I'm a bad person, right? I deserve to be punished, or I deserve to be persecuted. And so that would result in like a lot of guilt, some distorted beliefs about me being bad, right? Sometimes people even think that because they have schizophrenia, it is a punishment because they did something bad. And so I am bad is a workable core belief, right? So most of the things associated with psychosis that seem so different than some of the other mental illnesses turn out to not really be that different if we just kind of keep digging. And you don't need medication to change those beliefs. So I hope that helps with that answer, or that question, excuse me.
If I just add on to that, I would say that very common, you think about thinking errors that lead to different mental health disorders when you want to consider in psychosis is jumping to conclusions. So taking just a little piece of evidence and then, instead of going through all the steps to identify what's the most likely outcome, just jumping to a presupposed outcome. And so that process can be, you can help somebody learn how to have a little bit more cognitive flexibility around that, so they don't just automatically jump to a conclusion, but consider a variety of different causes for events.
Absolutely. And because I'm a psychologist, I have a biased answer. So let me take a step back also and acknowledge the importance of all the other support services. Like supportive employment is it has like some of the most evidence in improving well-being, which is associated with decreased symptoms, right? And so people can learn skills. People can at least even start with volunteering. The busier people feel, the more engaged people feel, the less severe symptoms are with or without medication. Do you have anything to add to that, Missy? Any experiences?
Honestly, not really. We can move on to the next one if you'd like.
Okay, great. Do we treat substance-induced psychosis differently than regular psychosis, I guess? And can we determine the difference? Anybody want to start with that?
I can jump in. You brought this up earlier about substance-induced psychosis in your talk. And I will say it's pretty difficult when somebody is experiencing acute psychosis to tell the difference. There are some patterns and some like timing things that can come into play that really sort of sway our belief about if it's substance induced or not. So for instance, if somebody's never had psychotic symptoms, smoked weed, got psychotic, didn't get any treatment of any kind, and the next day was fine, didn't have any psychotic symptoms anymore, that's probably a substance-induced psychosis, right? I think we can all see that pretty clearly. But the problem becomes when people are using consistently, sometimes the psychosis episodes can last longer and longer, and eventually people can end up still having psychosis even when they've been sober for prolonged periods of time. They can actually go from a substance-induced psychosis to a primary psychotic disorder. And one of the things that can be really tricky is when Dr. Warner was describing earlier, sometimes people can have prodromal symptoms of psychosis or schizophrenia, and then use a substance and then appear acutely psychotic. But that doesn't mean they didn't already have some symptoms present that just weren't being detected at that time. So it can be really difficult acutely to determine if it's substance induced or not. In general, if it's ever dangerous for them or someone else, you'd want to make sure that they're in a safe place and that they're getting support, whether that's through like psychosocial services or medications to help with the psychotic symptoms. But really like long-term observation is the best, in my opinion, to determine what we think is the most likely diagnosis.
I'm not sure if you covered it. Again, I was skimming through the questions. Would you treat medically it any different if someone comes in and it might be substance induced?
That's a great question. It depends on how clear cut it is. If it's incredibly clear cut, like someone comes into the emergency room, for instance, they had used methamphetamines, now they're psychotic, their family says, we've never seen anything like this before. A lot of times they just observe them without medications. They just keep them in a safe environment, give them hydration, do like blood testing to make sure there's no other reason they could be developing psychotic symptoms. But usually it's just observation. In order to even qualify as having a brief psychotic disorder, you have to have at least 1 day of symptoms. So observing them over a period of time will let us know, are these getting better off the substances or are they continuing to be present? And then you can make that decision about adding treatment. And then you can also make like long-term decisions about, do they need to stay on medication? Can you trial coming off medication? Things like that. And again, I'm providing a medication perspective because my role here as the medication prescriber, but there's a lot of other treatments that are available.
Great. And I think there was a question somewhere in here. Can substance-induced psychosis turn into psychosis? And I think Dr. Carnes touched on that briefly. And yes, absolutely. If we think about the stress vulnerability model too, right? Substances create a lot of stress on the body, stress mentally. And it's also a risk factor for psychosis. So when people are repeatedly using well, I won't say very often because I don't know the exact rates, but yes, people develop a psychotic disorder when they're no longer using sometimes.
When we talk about the numbers, I just want to add this because I think it's very interesting. I think in general, people, cannabis is so widely used that people have a conceptualization that it cannot cause psychosis or it does not cause psychosis. And I would say that with the way that it has changed over time, with THC concentrations increasing, we do see that there's more associated episodes of psychosis associated with cannabis. And some of the data shows us that if you have cannabis-induced psychosis and you continue to use cannabis, your likelihood of converting to a primary psychotic disorder, where you continue to experience psychosis even when you're not using cannabis anymore, is about 50%, 50. It's pretty high. So there's definitely some data out there about the rates of conversion. We obviously don't have time to go into all of that, but if you're interested, it's out there.
Yes, thank you. That was going to be my next question that I pointed out. Yes, and we know that like younger use of marijuana is one of the biggest substance risk factors for psychosis too, which is interesting because as a society, we don't think that it's necessarily like the worst, right? But it definitely contributes. The question is THC/CBD. I would be really hesitant with this information, but there is some preliminary research that suggests that CBD has a slight antipsychotic effect. So if people are going to use THC regardless, combination is usually best, but I wouldn't go around like, suggesting people use CBD just because. Okay, have a question here, but there was something I really wanted to get to. Can we speak a little bit to when involuntary admission is appropriate?
I can cover this one if that's okay.
Sure.
So involuntary admission is a big step. To override anybody's autonomy is a big decision, and you have to have a really good indication. And in order to determine when you can override that autonomy and force someone to engage in things like involuntary admission to a hospital or involuntary treatment, it's going to vary a lot based on your practice location and what your local laws are. So I work in Texas, so I'm going to speak specifically to Texas, but it's important to know that this is going to be different everywhere you practice, and you should know what those kind of rules are in your area. So in Texas, there's 3 criteria, and you have to have the person meet at least one of these criteria in order to force involuntary admission. And that is that they are an imminent danger to themselves, an imminent danger to others. The 3rd criteria is rather long, so I won't go through all of it, but it essentially boils down to that they are so psychiatrically sick that they are unable to care for their own health and safety. And for those reasons and those reasons alone, can you force somebody into a hospital or into treatment, overriding their own decision making?
Thanks. Might be a good question for Missy. Highly related. What role do you believe that coercion, like involuntary commitment or forced medication, should play in the treatment of individuals with psychotic disorders? And what can service providers do to address and mitigate the traumatic and damaging effects of coercion, which of course we know can be very traumatizing or re-traumatizing?
Honestly, I don't agree with either. I think even as acute as the psychosis or symptoms may be, I don't think certain practices should be forced on any of the patients or clients. But if they are harm to themselves or harm to somebody else, of course, obviously for their own safety, involuntary inpatient would have to come into play. As far as the medications, that's a really touchy one. My own experience with medications, voluntarily taking them, has been really horrific over the years. It is not a fun process. You don't get that first pill and that's a magic pill. It takes years, and there's all kinds of amazing, unbelievable side effects and so on and so forth. For someone in that kind of state to be forced to go through that on top of everything else, I really personally, morally don't agree with it.
Yeah, that makes sense. And unfortunately right now, it's a really frequent occurrence. Do you have any advice for service users as to how we can make things less traumatic if it has to happen?
I personally think that there should be a certain amount of time between admission and discussion about medication, and in that time there should be some sort of psychotherapy in that time to see kind of where the patient is at before any chemicals are put into them.
A lot of sense. I think part of the process that is pretty traumatizing too is when people are arrested for a mental health warrant, like on their way to a facility, which none of us are involved in. But I am aware that this probably differs by location, but in our location, there are some specific emergency numbers that you can call to request a mental health constable or someone be involved in that process, which I think can be really helpful. Any other thoughts on that? Is there a cure? Common question. Missy, you want to speak to that?
No, there's not. Unfortunately, and that's a hard pill to swallow, and it's a hard thing to say to clients. It really is. I hate having to say it, and I hate having to live it myself. But the thing is, there is recovery, there is balance, there is living with it, which is how I refer to my own disorder. I don't say that I have bipolar, I say I live with it, because there is that place in life that you can get to where it doesn't dictate your every day. But is there a cure? No, unfortunately, there's not.
Really great point about the importance of language. Using person first language is incredibly important, and not everybody does it, even within our discipline, which is very unhelpful. And when individuals call themselves schizophrenic, we often have a discussion about what that means and how that feels and how we can change that language a little bit. Go ahead.
Give an example of person first language, Dr. Warner.
Oh, sure. Someone with schizophrenia, or he has schizophrenia, or he experiences symptoms of psychosis. The person comes first, because really everybody is complex and has many different roles and values and strengths and weaknesses, right? And a mental illness or a mental health diagnosis is really a small part of who they are. And so by identifying someone as that thing is really self-stigmatizing and stigmatizing. And I think a lot of service users really struggle with that idea of being schizophrenic because it means to them that they're crazy and like all these other assumptions. So even just shifting the language for them to use it in a way can make a big difference on how they view themselves and what they focus on.
I just wanted to add that, yeah, I mean, I think that the language around the cure, it sounds like something that is done to a person. And so that's why we don't really look to the language of saying that somebody is cured, but there's a lot of variety of experience. Some people can experience episodes throughout their life, off and on, and some experience symptoms that are constant, could be for years or decades. And some people might experience one episode and never experience another episode again. So there's a lot of variability in terms of what psychosis can look like. And so I think that you're probably all of us are balking at the term cure, but that doesn't necessarily, just because we don't say that somebody is cured doesn't necessarily mean that they're going to experience symptoms the rest of their life.
Right. And partial or full recovery is absolutely possible. And I mean, I think we're a little biased because we're service providers for people that are struggling and seeking help. But like in the community, there are so many people that have severe mental illness that you would never know, right? They're managing their lives and their days like everybody else. It's something that needs to be managed. Don't know if we have 2 more minutes. Any other points that anybody would like to make?
I'm just really happy that people came to learn about this topic, and I hope that you found some useful tools and insights to take forward to help people in the future.
I agree, and I appreciate the fact that I'm assuming most people who are logged on are helping people get and maintain housing. And I just want to emphasize what's an important part that is of recovery for people with mental health conditions is having supportive, stable housing. So it's important work that you all are doing.
Absolutely. Yes. Thank you all for everything that you do. It is literally essential. It's really hard to improve mental health if you don't have your basic needs met. And there are a lot of folks that are providing these services or, enough. So yeah, thank you all. And thank you for having us. Jen, I had a quick question. Am I still going to have access to the Q&As in the future so I could respond to some of them, or how does that work?
Yeah, we'll make sure we get that to you. But yeah, I think everybody, which is a really great to say, we had over 300 questions just during the webinar. So I appreciate everybody's participation. We are going to have a continuing webinar series about psychotic disorders. So stay tuned to our listserv when we announce that in the coming weeks. And we will look at these questions. We'll talk with the team too to see what else we can answer and get that to you. Alicia's added the survey link for the evaluation and certificate of participation in the chat. We do sometimes overwhelm that website right after a webinar, so take a few minutes, try again. But with that, huge thanks. I feel like we could have continued this discussion all day. So big thanks to Aaliyah, Brandy, Amy, and Missy for sharing your expertise, for sharing your stories, and the message of hope and recovery. We appreciate that. So for all of our audience, we will see you again next time. Thanks so much.
Thank you.
Thank you.
Bye, everybody.